afternoon. In the year 2000, this lady entered my office with breast cancer. Mrs. A.P. She was a widow with a child 4 years old. After diagnosis, we treated her with the best of treatment that was available. In the year 2019, this lady started having dizziness and she fainted one or two times getting out from the bus. She was diagnosed with bradyarrhythmia. She had received anthracyclines when she had breast cancer, and now, just 20 days back, she was put on pacemaker. So, ladies and gentlemen, this is a very important topic for today, cardio-oncology, a new discipline highlighting the importance of cardiotoxicity with anti-cancer agents. So there has been a lot of advances in the rising number of cancer survivors, a huge burden projected by 2025, and cancer patients are at higher risk of heart disease because they have cardiotoxic medications. So as oncologists, our main aim is to find out a balance between the oncologic efficiency and the cardiotoxicity through various types of research. So what is cardio-oncology? It is an interdisciplinary field of medicine for studying the molecular and the clinical alterations in the cardiovascular system due to the host of all these therapy, chemotherapy, radiotherapy, etc. And efforts are to treat and prevent cancer therapy related cardiovascular problems because we have to treat them. So what best we can do by preventing the cardiotoxicity, that is the main aim of cardio-oncology. Like any other patient, a cancer patient also is subjected to all the risks of heart disease like hypertension, diabetes, the lifestyle factors like smoking, obesity, and we have a history of heart failure, MI. So all these are high risk. And of course, the treatment that we offer that adds to the burden of the risk. I'll show you two exemplary cases. All real-life cases, a 20-year-old male presenting with dyspnea at the emergency. He had received anthracycline for acute myeloid leukemia when he was 3 years old. There has been no routine cardiac follow-up during his survivorship, but the last decade he has been having occasional exertional dyspnea, 35% ejection fraction complicated by atrial fibrillation, put on left ventricular assist device in even later heart transplant, a very rich person's son, but ultimately died at 36 years. So this is an example of lack of cardiac surveillance. He never came for any follow-up after he was cured of his AML and did not have any cardiac surveillance. This is the benefit of cardiac surveillance. A 57 years old female referred to cardio-oncology clinic with mild tachycardia. She has just completed her 4 cycles of chemotherapy and targeted therapy of anti-HER2 trastuzumab, which is also cardiotoxic. She is asymptomatic, but the LVEF has decreased from 60 to 49%. The global longitudinal strain decreased from 20% to 17%. Carvedilol started and the LVEF has improved and GLS has normalized. So this is the benefit of cardiac surveillance. So friends, what are the cardiovascular adverse events with anti-cancer drugs? A host of things can happen like hypertension, coronary artery disease, bradyarrhythmia, tachyarrhythmia, QT prolongation, valvular disease with radiotherapy. But we will limit our talk in this limited period to myocardial dysfunction and heart failure. So this is known as cancer therapeutics related cardiac dysfunction, CTR-CD. The LVEF drop in symptomatic of more than 5% is enough to qualify as CTR-CD, or a drop in LVEF beyond 10% with some drugs and 20% with some other drugs, or a total LVEF less than 55% or 50%. So this is the definition as per the European Society of Cardiology and the European Society of Medical Oncology. These are all the potential cardiotoxic drugs, all of you know them, the anthracyclines, ifosfamide, cyclophosphamide, the taxanes. But what I want to highlight is we are using a lot of oral targeted therapy. They are very innocuous, but look, they have so much of cardiotoxicity, pazopanib, imatinib, So don't think just because you're taking an oral drug, you don't have to have a cardiac surveillance. All these are very important. So what are the mechanism of cardiotoxicity in these patients? Basically, they are the oxidative stress due to high collection of calcium in the cytosol. So in a nutshell, this is the reason or the pathomechanism. So initially there is myofibrillar disorganization followed by apoptosis, as you know, and gradually there is myocyte necrosis. So it becomes irreversible as time goes on. What are the varieties? Basically, there are two varieties. Type 1, the anthracycline, type 2, like the anti-HER2 trastuzumab. Here, there is irreversible myocardial death of the myocytes, cardiomyocytes. Here, there is dysfunction. So, generally, this is reversible, this is irreversible. There is a cumulative dose in this type of toxicity, but there is no cumulative dose in the type 2 toxicity. So, this is what I said. Basically, anthracycline is the role model of cardiotoxicity, and they inhibit this very important enzyme topoisomerase 2B, and hence there is irreversible damage of cardiomyocytes with mitochondrial dysfunction. The cumulative dose that is cut off of around 300 milligram per meter square, but there is a lot of inter-individual variability. All anthracyclines are not the same. There are different varieties with a different cutoff. The relative cardiotoxicity is different with these. So what really happens when you have an anthracycline? You can have an acute onset LV dysfunction just after chemotherapy. You can have a chronic progressive type within 1 year, partially reversible, and this is the most dangerous type that can occur decades after you receive anthracycline, like in my patient which I showed you in the beginning. This can occur, and this is chronic progressive more than 1 year after completion of chemotherapy, and this is irreversible. We come to the type 2 CTR-CD. This is reversible, no cumulative dose, no ultrastructural change in the myocardium, and the beauty is that you can re-challenge with the offending drug once your ejection fraction normalizes. So this is what happens with trastuzumab. 20% only have a lack of reversibility. Around 80% they recover from that acute toxicity. So coming to the methodology for diagnosing or having surveillance with cardiotoxic medications in cancer patients. Most commonly used is, of course, echocardiography. This is having one limitation, that it is observer bias. Muga scan was very much used in nuclear medicine before, now limited use because it cannot give you any structural information. Cardiac MRI is very, very good because it can diagnose myocardial fibrosis, but you know it's very costly, not widely available. And the cardiac biomarkers like the NT-proNB, proBNP, and the HS troponin, these are not having any evidence for surveillance in the different trials of cardiotoxic medications in cancer. So, what imaging techniques will we adopt to detect cardiac dysfunction? If you are following up these patients, if you have the chance of using 3D ejection fraction, that is superior to even cardiac MRI. I can tell you in my institution, I don't have any facility for this. This I have taken from the research studies. And as I showed you before, the longitudinal strain pattern has been established to be much superior to the ejection fraction in patients who have received cardiotoxic medications and you are following them up. Cardiac MRI is very good if you have the facilities. Why? Because it identifies all these changes in the myocardium, like edema, fibrosis, and I showed you that anthracycline, it is mainly a mitochondrial damage, a dysfunction, gradually leading to irreversibility because the myocytes will ultimately die after apoptosis. Whereas in trastuzumab, anti-HER2, you know, HER2 is a target on the cells of the human body, human epithelial origin. And if you have an anti-HER2 drug that you are using, it will also cause some toxicity in the cardiomyocyte by oxidative stress. But this oxidative stress that it creates is reversible. So in these patients also, you have to do a 2D EF to follow them up. Once it normalizes, you can re-challenge with the drug. Cardiac MRI actually identifies all these structural changes, whether it is edema, which is reversible, or whether it is fibrosis that is not reversible. Remember, anthracycline causes more of a myocardial dysfunction like lowered ejection fraction, whereas anti-HER2 trastuzumab causes more of a dilated cardiomyopathy that reverses. What is the treatment? ACE inhibitors, ARBs, beta blockers, I don't have to tell you all these. These are actually recommended in the symptomatic patients. There are a lot of prevention strategies like enalapril, carvedilol that have been used in these prevention strategies. ARBs, ACE inhibitors or beta blockers have no effect on the trastuzumab related cardiotoxicity. All these ARBs or enalapril, carvedilol, they have some data in anthracycline related cardiotoxicity, and the very important drug that has come up in the last decade is dextrazoxane, which is a cardioprotectant that can be used if you have a cumulative dose of doxorubicin that is more than 300 milligram per meter square. So friends, there are lots of ongoing trials globally to find out how we can prevent cardiotoxicity with the use of statins, with the use of in patients who are receiving anthracycline. The results of these are not yet out. The PREVENT, STOP CA, SOCCER actually uses the GLS, the longitudinal strain pattern, to do a surveillance in the patients who are receiving chemotherapy with cardiotoxic drugs. This is one of the most important prospective trials that will show whether the GLS actually is better than ejection fraction. So ladies and gentlemen, I come to the end of my talk. I pay my respect to the revolutionary change in hyperdrive that led to the birth of comprehensive cardiovascular disease clinic in collaboration with the oncology clinic. So cardio-oncology started in the MD Anderson Cancer Center in July 1st, 2000. It is a very full comprehensive program to diagnose, treat, manage all CVD in cancer patients and the survivors. It has become so important that now we need more specialists with certified training in cardio-oncology. And this was one of the biggest summit on cardio-oncology held recently, with all these very important international societies contributing to the data that was generated from this meeting. Thank you for the very patient hearing, and my time is already up. Any question?
If there is any one or two question to Madam. Now I have one question.
Not much related to cardiology, I can't answer.
We regularly do encounter this problem. Now whether giving medication to protect heart and to continue the chemotherapeutic agents which are causing cardiotoxicity, whether that is rational or we are to, for the timing, we tell.
Very important question. See, I have stated this. If you want to prevent cardiotoxicity, then you have to start it from the day one when you're using that drug, not when they develop, because once they develop, say, anthracycline toxicity, you cannot use that drug. But trastuzumab is one such drug where even after the toxicity, you can stop the drug for some time and re-challenge later on. So these are the very important drugs that have evidence-based, enalapril and carvedilol, whether they can actually prevent the ejection fraction decrease. So that is the way to prevent cardiotoxicity with such medications. Yes, Amulda had one question. Oh, okay.
Mic, please.
Thank you, MadhuChanda, for highlighting some, I would rather say, emerging area of internal medicine. Many patients are having the anti-cancer therapy and also radiotherapy. They are prone to develop the LV dysfunction. You have rightly pointed out that even when the ejection fraction is normal, this is the protocol of each and every oncologist to undergo what you have suggested. We also suggest the GLS.
Yes.
If the GLS is 15% minus 15 or below, then it is better to go for, we should be very cautious regarding 2 or 3 drugs. When the breast cancer, hearts therapy, and also anthracycline group of chemotherapy agent. And then you oncologists, you know that what are the drugs should be used in such situation. And you also, there are two drugs, age-old drug like enalapril, it is given when GLS is lower.
Yes.
GLS is a reflection of the systolic function even when the ejection fraction is normal. And also candesartan, by some trial, it is superior. There are, I think, the enalapril and the beta blocker, particularly some trials are with the carvedilol. These are the drugs which you can use, but it has never shown that it can reverse the cardiac changes which has been already caused by either the radiotherapy or the anti-cancer therapy. Thank you.
Yes, these are all preventing from the day one. And candesartan was shown to be better than beta blocker in this trial. So my main aim was to sensitize the physician population that this is a very important new stream in oncology and cardiology, and collaborative work can actually help us with a lot of research in this field. Thank you.
Okay, thank you to MadhuChanda Kar.